Right. Good evening. So we are meeting again another free class, right? So this is our third free class. So we'll do some free class series. As I told you, we'll do free class series until they announce the exams, right? So then you all can continue to have a touch with obs and gynae, isn't it? Right. Okay. So hope you all have the paper. So I have sent today morning. So we'll start the paper discussion right now. So these are the few papers. So if you want additional paper discussion or maybe a theory or revisions, you can join to the classes and you will get to know those things. Okay, right. We'll start. Paper number 3, we will start with the MCQs, right? So absolute indication. The first MCQ is absolute indication for cesarean section, right? That is the first question, right? So what do you understand by absolute indication? So we know what is cesarean section. Cesarean section is another mode of delivery, as we discussed last class as well, right? So I would like to see few students. Yeah, it is nice to see your face when I'm doing the class. So this will make the class very interactive, right? So please switch on your camera and I can see your expression, whether you can understand, you are understanding, whether it's difficult to understand. So it's easy for me to do that, isn't it? So please switch on your camera, and I'm expecting you to participate. So you all have I'm expecting you to answer the questions, right? So then it will be easy for us, because rather than doing like one-way lectures, right? So if it is kind of interactive session, so it is easy for us to understand, right? So whenever you have question, of course you can ask, right? Okay. So absolute indication for the cesarean section, lower segment cesarean section. So why we are doing the cesarean section? So few things we discussed about the cesarean section last time also, last class, last paper class also. What is cesarean section? As we know, like it's an alternative method of delivery of the baby, right? It is an alternative method. So if the delivery is not possible through the vagina, we need to cut the mother through the abdomen. Especially we are cutting the lower part of the uterus, because there are a lot of advantage to cut the uterus in the lower segment. So cesarean section why we do the cesarean section is to deliver the baby by another method, right? Yeah, deliver the baby by another method, right? So that is why we are doing the cesarean section. Do you all understand? That is why we are doing the cesarean section. Great. So why? What are the indications, right? So you need to know a few things about cesarean section. So you will get questions. So always you need to have a targeted studies towards the exam, right? Because you all have to understand what is exam. Exam is how you are reproduce your knowledge, right? So what you are studying, how much you know, how many hours you are spending per day. It's not depending your pass, right? So always, if you are my students, you should know how to reproduce your knowledge, right? So you are studying the theory, right? So I'm teaching. So then we are doing the question. So when we are studying, or when we are doing the question, how you are reproducing. So in that 2.5 hours, when you are doing the question, how you are reproduce your knowledge, that will reflect your answers, so your marks, pass rate. Do you understand? So you should know how to reproduce your knowledge. So for that, I can help you. What are the common things, and what are the things you must know, right? And of course, you need to know the pathophysiology. Always you need to know the pathophysiology, because each and every question, if you understand from the pathophysiological explanation, so from the basics, it's very easy to pass, right? So that is the simple explanation why my students are passing more than 90%, because most of my students know the basics. They know the basic of the obstetrics and gynecology, right? So in cesarean section, what are things you need to know? First of all, you need to know the indication. What is cesarean section? What are the indication, right? So what are the type of cesarean section, right? So how to prepare the patient for the cesarean section? What are the complications of cesarean section? These are the common area you will get the questions. So that day we discussed. So beyond the cesarean section, you could get some question here like in VBAC. What is VBAC? Vaginal birth following cesarean section. After cesarean section, if somebody underwent cesarean section, then after that she want to go for a vaginal delivery, that is called vaginal birth after cesarean section. So in that case, you need to know what are the problem occur or what are the things they will ask in the VBAC. So obviously in cesarean section, you need to know these things: indications, type, preparation, complications, right? So you should know what is cesarean section. So this is how they're asking. So what is cesarean section and what are the type of cesarean sections are? So alternative way, maybe upper segment cesarean section, lower segment cesarean section, right? So why we do lower segment cesarean section? What are the advantage? What are the disadvantage? Why we do upper segment cesarean section? What are the indication for the upper segment cesarean section? What are the advantage of upper segment cesarean section? What are the disadvantage of upper segment cesarean section? These are the things you need to know. Even somebody wake up in midnight, hello Malshi, what are the indication for upper segment cesarean section? Then you need to tell, oh, This is how you need to study. Do you understand what I'm telling? Got it? Great. So this is how you need to study. Very good. So here, the type of cesarean section, the last week we discussed, the last paper we discussed, like category 1 cesarean section, category 2 cesarean section, category 3 cesarean section, category 4 cesarean section. Right. So we will discuss about the indication of cesarean section. So in theory class, we already discussed about the cesarean section in elaborative manner. So here, of course, I can't discuss in elaborative manner because within 2 hours, I need to finish all these 20 questions. So it is not possible. At least the relevant things and adjacent important one, we will discuss. Okay. Indication for cesarean section. Okay. Just tell me some indication of why we are doing cesarean section. Anyone, please? What are the indication for cesarean section? Anyone? I'm expecting some answer from students. What are the indication for cesarean section? Okay, grade 3 modeling. Okay, transverse lie, right? So if the baby is in a transverse position, obviously baby can't come out, right? Baby can't come out. So malpresentation, malposition, abnormal lie, right? So because this, as we know, if the baby want to come, head should be in the lower part, right? The vertex should be in the presenting part. So we studied all these things in theory classes. So if it is an abnormal one, obviously you can't deliver the baby. Do you understand? Right. So because it is not possible, as we know, in labor, we have 3 P's. What are those 3 P's, please? What are those 3 P's? In labor, passage, and power. Right? So if you have problem in your passenger, the baby, abnormal lie, abnormal presentation. So if it is a problem in your passenger, obviously this labor might get obstructed and this journey will not continue. So then you can't complete this journey. Then you need to find another way. Like if you are applying for this ERPM exam and you are doing something problem, you couldn't do it. Then you can't waste your time because this journey will not complete. Then what you do? You find another way. AMC, PLAB. Do you understand? So that is how we deliver the baby also. So we are trying to deliver the baby through the vagina. It's not possible. It will not happen. So then no point in waiting. So then what are we doing? We just cut the mother and take the baby out in a different way. Somehow you need to pass. Right? So you are studying alone, obs-gynae, this time fail, second time fail, third time fail. It's failed to progress. Then what you do? You are coming to my class. This is the alternative way. Then we are taking you through the ERPM class in a different way. Do you understand? So that is how it is. So problem in the passenger or problem in the passage. What is the problem? The passage is not adequate to allow the baby to come out. Or something is obstructed your passage, like placenta is in the lower part. So baby can't come out. Definitely can't come out. Baby is larger than the passage. How do you call that? Very good. Cephalopelvic disproportion. Head is larger than the pelvis. Obviously, the bigger baby can't come through the small path because the head is bone, pelvis is bone, right? So this journey is like a boyfriend-girlfriend relationship, right? So because both are bone, negotiations are less. So then there will be a fight between them. But if they have some kind of negotiation, when the baby is turning and flexing and molding, and mother also trying, so there are some negotiation to complete this journey. Everywhere you need some negotiation to complete your journey, right? So everywhere you need some negotiation. If you don't have negotiation, ultimately you have to go for a cesarean section. Otherwise, you can't complete your journey. You have to find another way. Do you understand? So cephalopelvic disproportion. If it is a cephalopelvic disproportion, there is no option. You need to take the baby through the abdomen. Right? So something is blocking, like placenta, morbidly placenta, placenta previa, or lower segment fibroid. So the fibroid is obstructing, right? Or sometimes the fetal distress. You can't wait for the delivery. There is no time. Cord prolapse, right? Fetal heart rate abnormalities. So then you can't wait. If you wait, baby will die. So then you have to take the baby immediately. Baby is not progressing, right? Few things like maternal condition, like previous 2 cesarean section, 2 or more cesarean section, upper segment cesarean section. Because if you allow this mother to go for a vaginal delivery, uterus might rupture and patient will die. So uterine rupture risk is a bit high. So that's why you are cutting the mother. Some maternal condition, right? So severe preeclampsia, right? Or maybe a fetal condition like absence or reverse diastolic flow, severe IgG, right? So like that. So there are so many indications. So here they are asking absolute indication. Absolute indication means you don't have any option, only cesarean section, right? Bro presentation. What do you think? Absolute indication for cesarean section. Bro presentation. Yeah, that's true because yeah, very good. Yeah, as we know, it is a malpresentation. The pelvic diameter is maximum diameter is 13 centimeter laterally and anterior posterior is 11 centimeter. But when the baby is in a bro presentation, presenting part cross diameter is 13 centimeter. 13.5 centimeter. It means your anterior posterior diameter is 11. The presenting part diameter is 13.5. Obviously, this fetal presentation will not go through the smaller pathway. Definitely, because the space is not adequate. 11 centimeter won't allow 13.5 centimeter structure, isn't it? So you don't have option. You have to take the baby through the upper. So bro presentation, yeah, that's true. Twin pregnancy, what do you think? Twin pregnancy obviously false. Sometimes you may have to do this twin pregnancy, but if they mention like blindly twin pregnancy, false. Because as we know, if it is a non-cephalic presentation of leading twin. So what do you understand by these, right? So first few things you need to know about the twin pregnancy mode of delivery: chorionicity and amniocity. Right? So if 2 babies are in a separate sac, you don't need to worry. But if 2 babies are in the same sac, monochorionic, monoamniotic, you can't go for a vaginal delivery. You have to do the cesarean section. But if it is a dichorionic diamniotic or monochorionic diamniotic, if 2 babies are in different amniotic sac, you don't need to do the section because of the amniocity, but you need to decide which mode of delivery you can do. That is depend on the leading twin. What do you understand by leading twin? The first twin. The first twin, right? Usually the first twin, how the first twin it is. If the first twin is in the cephalic presentation, you don't need to worry. You can go for a vaginal delivery. But if the first twin is non-cephalic, maybe in the oblique lie, transverse lie, breech, whatever, we are worrying only about the first twin. Because if the first twin is cephalic, second twin is non-cephalic, we don't worry. We just deliver the first twin, second twin we can turn and deliver. It's not a problem for us. But if first twin is non-cephalic, maybe breech or transverse lie, You can't do ECV, you can't do any intervention if it is even the breech. So if the first twin is cephalic, non-cephalic bleeding twin, always an indication for cesarean section. You have to keep it in your mind. But here they didn't mention in that clear manner. Just ask twin pregnancy. Twin pregnancy itself, it's not an indication for the cesarean section. So if it is a non-cephalic presentation or maybe like a monochorionic, monoamniotic, yes, right? So twin pregnancy false. Anemia, if hemoglobin is less than 9.5, true or false? It's false. Very good. Because anemia, it's not an indication for cesarean section. But only problem when you go for a vaginal delivery, she has high risk for the postpartum hemorrhage. Right? So even if it is a cesarean section, it's a risk for the postpartum hemorrhage because it might fail to contract the uterus. Anemia, it's not an indication for the cesarean section. It's false. Inlet transverse diameter is less than 9.5 centimeter. True or false?
True.
Yeah, true. Very good. Because as we know, the commonest presentation of the baby is vertex presentation. It means the baby is in a very well flexed position. So the vertex will be the lowermost part, vertex presentation. Or baby might be in a hyperextended position. How do you call that presentation? That is called face presentation. Very good. Hyperextended is face presentation. This face presentation and vertex presentation, the presenting diameter is 9.5 centimeter. Right? So presenting diameter is 9.5 centimeter. But as I told you a bit early, the pelvic inlet diameter is 11 centimeter. So through this 11 centimeter inlet, this 9.5 centimeter presenting part can easily enter. So then this journey can occur. Do you understand? But if the inlet is less than 9.5 centimeter, what will happen? The presenting part will be bigger than the pelvis. Then obviously, baby can't enter into the pelvis. Do you all understand what I'm telling? Right? So always, so just knowing the answer is nothing. You can get the answer from your colleagues, your seniors. It's not a big issue. Yeah. But you need to know what is the reason. That's why you are coming to my class. Right? So pelvic inlet diameter is less than 9.5 centimeter means this is going to be a cephalopelvic disproportion. This is going to be a cephalopelvic disproportion. So obviously baby can't deliver vaginally. You need to go for a cesarean section. That's true. RH sensitized mother. True or false? It's false. Yeah. If mother RH sensitized, only problem, mother has antibody. This antibody will cross the placenta and baby will have hemolysis. That is our problem. Other than that, we don't need to deliver the baby by cesarean section. Right? So sensitized mother or non-sensitized mother, it's not an indication for cesarean section. HIV positive mother, viral count is 500 per milliliter. Viral RNA copies per milliliter. It is an indication or not? True or false? True. Absolute indication. If it is more than 400, it is absolute indication. Right? So I think we have discussed, we will discuss those things in a HIV question as well. So this is how we are answering the question, right? So answer for question number 1, true, false, false, true, false. Okay. You don't need to worry. So if you students now only, they have graduated and they are preparing the classes. So hopefully you don't need to worry. So we will continue this paper class. You can attend to this paper class and get some knowledge. And of course, I would suggest you to attend to this class as theory class, because if you attend to the theory class, you will have a background knowledge. When we are doing this revision and papers, it will be easy for you, right? So because if you have a background, especially you just tell your juniors, because if the juniors come to the class, so say most of the students, you are attending the class first time after graduating, so you have only one chance to get the understanding about the subject. But if somebody attend to the classes during the junior period, so maybe the second year, third year, fourth year, final year, so you are going to get the recorded classes, lifetime access, and free the live classes, unlimited access. So once you pay, you can attend several times. So then when you come to the ERPM, obviously you will have a good knowledge, right? So I'm really sorry. I'm getting a bit delayed to launch my platform because of few security things. We are waiting for the Apple Apple Store approval, right? So once we get that approval, so my primary target is like that. So I'm going to give you the restreaming or the recorded classes which I have conducted in a small topic wise, in a very nice narrowed mind with the bookmark and all, for 24/7 lifelong access. So this platform is going to be student friendly one, right? So it is good for you. So you will get the lifelong access even when you become a house officer, become a registrar. If you have doubt, because I'm targeting to do these things for the postgraduate as well. So if you have doubt, you can go to the particular topic, particular risk factors or something like that, and you can watch it. That's it, right? So the relevant material, additional reading material, everything will be available in the platform, right? And also you can join yourself. Everything is automated. You don't need to contact the coordinator. You can get into your classes. You can get into your live classes. So I'm planning to do 2 live classes per year. So then you can join to the live classes as well if you want, right? So it is going to be a 24/7 restream access also. So every class will be available, right? Paper class, theory class, Viva class, everything. So the students who miss the class, you don't need to worry. You can join anytime. Once you join, you are getting the access. So you will get access for your life in the future, like paper class as well, the theory class as well. So we are in a checking phase now. So it is taking some time, but anyhow, maybe 1 or 2 weeks, we hope to launch it. We'll see. We are waiting for the approval, that primary device verification approval. So because few security things we need to do, because as we are giving 24/7, we need to prevent the unwanted actions, right? So for that, we are having few security things. And of course, as you are getting 24/7, zero tolerance for misconduct, right? So you will be immediately terminated from the course. Then if you want to join, you have to pay again. You are losing all the facilities which we are providing to you. And second thing, that is it's a different platform. I'm joining with them to do these classes. So then as I am joining with them, so this is the intellectual property of them. So if you record it, they will get the notification with the evidence. Then of course there will be a court case. So hope you will understand. And because if you get 24/7, why you want a record? No need, right? So is it available to watch from the phone as well? Yeah, of course. It is a web page, web platform. So with the phone, computer, tab, wherever you can log in and you can watch it. It's not a problem, right? So hopefully it will be a student friendly, right? So there are so many facilities and classes and a lot of things we are planning, question bank and a lot of things. We'll see. With time, we will understand. How many times watch one video? That's up to you. It is unlimited. That is how I'm planning. So once you join, it is unlimited, 24/7. Anytime you can watch, anytime you can study, right? So question number 2, anemia complicating pregnancy. Can we fast forward the video? Yeah, of course. There are so many things. You can once we launch, we'll see. You can fast forward. If we have paid for the module now, can they access them through the app later? Yeah, of course. So the students who join to the classes after I start the online session will get, all the students, previous students also will get the access, right? So yeah, of course, you can fast forward, you can select the video quality, everything will be available. Yeah, fine. So anemia complicating pregnancy associated with preterm labor. True or false? Yeah, of course, it's true. because anemia has risks for the several things: preterm labor, PPROM, IUGR, placental abruption, right? So an infection. So anemia, and postpartum hemorrhage, right? So which can associated with preterm labor, of course, yes. So there are so many reasons for the preterm labor. One is your placental membrane is not stable. Second one, anemia is a risk factor for infection. When there is an infection will produce the prostaglandin. Once the prostaglandin produced, prostaglandin will stimulate the labor, right? So yeah, of course. So then it will be a risk factor for the preterm labor, right? So associated with preterm labor, that's true. Indication for elective cesarean section, false. Anemia, it's not an indication for cesarean section, I told you. If it is an anemia, just give the blood and deliver the baby. That's it, right? So it's false. Diagnose if hemoglobin is less than 13, true or false? So if it is a non-pregnant mother's, 13 is yes. But for the pregnancy, because of the fluid overload, fluid retention, there will be a physiological anemia, right? There will be a physiological anemia, right? Because of this physiological anemia, WHO has revised the cutoff for the pregnancy, right? And especially in each and every period of gestation, like trimesters. We know what is trimester: the first 12 weeks, 12 to 28 weeks, 28 to 40 weeks, and after the delivery. So every trimesters, your fluid retention level will vary. So especially in second trimester, from 12 weeks to 28 weeks, maximum fluid will retain, right? So depend on the fluid retention level, the cutoff for the hemoglobin to diagnose the anemia, it's vary to every trimester. So if it is first trimester and third trimester, cutoff is 11. Second trimester, cutoff is 10.5. Right? So in postpartum period, cutoff is anyone? 10. Right? Obviously, we know after the delivery, mother will bleed a lot. So then 10. So this is how we are diagnosing, not 13. So diagnose if the hemoglobin is less than 13, false, right? Predominantly due to folate deficiency in Sri Lanka. More than 95% of Sri Lankan mothers' anemia is due to iron deficiency anemia, right? Not the folate, because our iron consumption is very, very poor in Sri Lanka, right? So I'm always telling to my students when I'm doing the class, as we know, right? So we are having we are buying the chicken once in a week, 6 members family, 1 kilo chicken for 2 meals, lunch and dinner. Sometimes we have to think whether it's really chicken or potato curry, because we put more potato than chicken and put the gravy, right? So that is how we are preparing. So that is how we are taking the iron. So very less iron consumption. Of course, the iron deficiency is the most common one, predominantly due to a folate, false. Treatment with parenteral from closer to the term. You can treat them closer to the term, IV iron. So actually, IV iron, we are giving the oral iron, right? So IV iron, we don't give routinely. We give the oral iron for certain instances only. Why we don't give IV iron to the mothers routinely? Because IV iron has high risk to develop anaphylactic shock. Right, so you need to admit the patient and you need to give as an inward patient, because it can cause anaphylactic shock. So what are the indications for the IV iron? Yes, please. What are the indications for the IV iron? Yeah, Malshi. What are the indications for the IV iron? Anyone? One, if the patient is yeah, of course. If the patient is not tolerable to the oral iron, because oral iron is like obs-gynae, it's not a tolerable subject, right? So intolerable, feel vomiting, difficult to study, difficult to understand. So like that, the iron treatment also like that, right? So intolerable. So if the patient couldn't tolerate the oral iron, then you have to give IV iron. Or if the patient is poor compliant, you are giving iron, she's not taking, so then just give the IV iron. There is no option, right? Third one is, if the patient need quick recovery of hemoglobin, say for example, near to delivery, say hemoglobin is 9, the target hemoglobin is 10 before delivery, POA is 36 weeks. So if you give oral iron, it takes some time to recover the hemoglobin. Right? Right? So yeah, thank you, Lahiru. So this takes some time to recover. So in that case, what you can do, you can give the IV iron. When you give the IV iron, what will happen? The recovery will be a bit fast. So if it is near to term, near to delivery, you can give. So treatment with parenteral iron closer to term, yeah, that's true. Closer to 37 week, EV can give because quick recovery, true. So answer for question number 2, true, false, 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 true. Right. Question number 3. A patient presented with abdominal pain, hypovolemia, tachycardia. So how long does it take to recover hemoglobin with oral and IV iron? So it's usually like this. If you give oral iron, the hemoglobin recovery in 2 weeks time, right? So hemoglobin will increase by like 0.5 to 1 gram per week, right? If it is an oral. But IV, definitely in a week time, more than 1. So the recovery will be 1. Right? So we are giving the IV iron, right? Okay. A patient presented with abdominal pain, hypovolemia, tachycardia, right? What are the differential diagnoses? So here, these are not a straightforward question. You need to understand. Your brain has to process, right? So here, what are the presenting complaint? Abdominal pain, right? So what could be the reason for the abdominal pain? Maybe a ruptured ectopic, or maybe some inflammation, or maybe some abdominal or peritoneal irritation. Those are the reasons, right? So ruptured something like ruptured cyst, ruptured ectopic, right? So these are the things will cause pain. That is one. Second, infection, right? So what are the infection? Peritonitis, right? Tubo-ovarian abscess, right? Infection. Third one is irritation, peritoneal irritation. So can you just tell me few things can cause peritoneal irritation? The free fluid in the peritoneum, free blood in the peritoneum, right? Ruptured ectopic. When the ectopic rupture, bleeding will be inside the abdominal cavity. That free blood will irritate the peritoneum and cause pain. Or fluid leakage, ovarian hyperstimulation syndrome. When it is leaking, what will happen? It will stimulate, irritate the peritoneum, cause pain. So those are the reasons for the abdominal pain. And now hypovolemia and tachycardia. Of course, if it is a hypovolemia, definitely they will have tachycardia. So what are the conditions can cause hypovolemia and tachycardia? Bleeding into the abdominal cavity. Fluid leakage into the abdominal cavity. When the fluid is leaking, what will happen? The blood volume will come down. Right? When the blood volume come down, tachycardia. Postpartum hemorrhage, obviously, if the postpartum hemorrhage is coming outside, obviously it will cause hypovolemia and tachycardia. But how can we explain the abdominal pain in postpartum hemorrhage? So you can't explain the abdominal pain in postpartum hemorrhage. Anyhow, here they are asking abdominal pain, hypovolemia, and tachycardia. So if you think in that way before you see the answers, okay, what are the conditions good? So then now you have some idea about the question. Now you can come to the answers. Like, see, ruptured ectopic, true or false? Ruptured, yeah, obviously true. Once the ruptured, ectopic ruptured, it will cause pain. And second one, bleed inside. Free blood will irritate the peritoneum. So bleeding inside will reduce the blood volume, tachycardia. Do you understand? So ruptured ectopic, true. Ruptured corpus luteal cyst. Ruptured corpus luteal cyst, true or false? Yeah, if a cyst ruptured, what will happen? Once the cyst ruptured, you will develop pain. And from the ruptured cyst, patient might start to bleed. From the ruptured cyst, they might start to bleed. If there is no bleeding, obviously pain only will be there, not the tachycardia and hypovolemia, right? But if the corpus luteal cyst ruptured and bleeding, then patient will develop continuous abdominal pain, tachycardia, and hypovolemia. So each and every girl will have a ruptured corpus luteal cyst because you are you are mensurate, ovulating, corpus luteum will form, then corpus luteum will rupture and it will disappear. Then again, next cycle will come. So this is your normal cycle. Everyone might have mild pain, not persisting pain and tachycardia and hypovolemia. But when there is a bleeding, yeah, of course. So ruptured corpus luteal is true. Adenomyosis. So adenomyosis is false, right? So because adenomyosis will not cause acute blood loss. When we will develop hypovolemia and tachycardia? When we have acute blood loss or acute fluid leakage. In adenomyosis, what patient will have? Patient will have abdominal pain, I agree. Patient will have heavy menstrual bleeding, yes, but it's a cyclical one, right? So when they have cyclical bleeding for a long time, what will happen? The blood will lose, the blood volume will restore with the free fluid, your fluid, tissue fluid dynamics, right? So blood volume will be maintained, but patient will be anemic. Do you understand? So patient will be anemic. Because of the anemia, patient might have tachycardia, but blood volume will be maintained. She will not be hypovolemic because it is chronic condition. In chronic condition, what is the difference between the chronic condition and acute condition? In chronic condition, you have time for the recovery of your fluids. But in acute blood loss or acute fluid leakage, you don't have time for the recovery. Say like diarrhea, vomiting, PPH, ruptured ectopic. So she's bleeding a lot. Suddenly she's bleeding. So you need some time for the recovery. To recover the blood volume by your body, you need some time. So during that time, patient will develop hypovolemia. So in adenomyosis, it is a long-term process. You have time for the recovery. So blood volume will be maintained, but she will be anemic. So pain will be there. Tachycardic might be there because of the anemia, but blood volume will be normal. No hypovolemia. Do you understand how extent we are thinking about the question? Do you understand? Oh, no. 450 students keep quiet means you don't understand what I'm telling. Is that so? Understood? Okay, thank you. Right. So adenomyosis false. Ovarian hyperstimulation syndrome. What do you think? Ovarian hyperstimulation? Yeah, of course it's true, because in ovarian hyperstimulation syndrome, what is the meaning of ovarian hyperstimulation syndrome? When more than one follicles are stimulating and developing, some chemical mediators will release. Those chemical mediators will increase the permeability and fluid start to leak into the space, especially in the peritoneal cavity. So when the fluid is leaking into the peritoneal cavity, so peritoneal cavity will have some free fluid which will irritate the peritoneum. Patient will have abdominal pain, abdominal distension. At the same time, fluid is leaking quickly, so blood volume will reduce, hypovolemia, renal failure, tachycardia, all kind of presentation as your PPH. So ovarian hyperstimulation syndrome, true. Fibroid degeneration, true or false? No. Fibroid regeneration can cause abdominal pain, but which will not cause hypovolemia. Can it cause tachycardia? Fibroid degeneration, can it cause tachycardia? Any people with brain matters? Any student with brain matter, please? Fibroid degeneration can cause tachycardia. True or false? Okay. True. Why? If you say something to me, I always ask why. You need to know the answer, reason. So if you don't know the reason, no point in knowing the answer. Why? Very good. Because of the pain. Pain can activate your sympathetic. Right? So pain can cause tachycardia. Will you have hypovolemia? No. Do you understand? So always you have to think very depth. You have to go. That's why I told you at the beginning, you need to know the pathophysiology. What is happening? Without knowing the pathophysiology, obviously you can't. Relative ischemia in red degeneration can cause tachycardia. Very good. So those are the reasons. Tachycardia can be there. Very good. But Hypovolemia, it's not possible. So it's false. So answer for question number 3, true, true, false, true, false. Good. We'll move to question number 4, method of cervical ripening. What do you understand by cervical ripening? What do you understand by cervical ripening? Anyone? What do you understand by cervical ripening? Okay. So when the labor starts, there are 2 things has to be happen. Right? One, so if you check your cervix now, right? If you check your cervix now, how will be your cervix? Your cervix will be hard in consistency and 4 centimeter length, and it's closed. Are you agree with that? Is it open? No. It's 4 centimeter length, hard in consistency, and hard or firm in consistency, like 4 centimeter length. Why? Because you are having a lot of fibrous tissue in your cervical tissue, cervical stroma. What will happen in the labor start? Usually, the cervical fibrous content will reduce and cervix will become soft and cervix start to dilate and baby's head will come down. When the baby's head come down, what will happen? Your cervix will incorporate into the uterus like blooming your balloon. When you are blooming your balloon, what will happen? The piece near to your mouth will incorporate into the expanded part, right? So like that. So that is called cervical ripening. The cervix is getting ready to allow the baby to come out. Same time, you need another event, that is your uterus need to be contracted. Uterine contraction. Do you understand? So there are 2 things need to be happen. One is cervical ripening. Second one is uterine contraction. How does uterine contraction occur? Because the uterus start to respond to oxytocin. What is oxytocin? Oxytocin is a hormone which is secreted by the posterior pituitary that will cause uterine contraction. But until the labor start, your uterus is not responding to the oxytocin because oxytocin receptor level will be very low. When the labor progress start, the oxytocin receptor will increase by 100-fold. So who is increasing the receptor count? So what is responsible to increase the sensitivity of the oxytocin is prostaglandin. So prostaglandin will do the sensitivity, will increase the sensitivity of the oxytocin. So then uterus start to contract. So one work has been started. Second one, your cervix need to be prepared. That is cervical ripening. So how the cervical ripening will occur? So cervical ripening also will be stimulated by the prostaglandin. This prostaglandin will stimulate proteolytic enzyme. Those proteolytic enzymes will hydrolyze the collagen fibers and elastin fibers and fibrous tissue. So then your cervix will become soft and effaced. This is called cervical ripening. So ultimately, if you see what is the chemical mediator is responsible for the induction or starting of labor is the prostaglandin. So prostaglandin is the one ripen the cervix, make the uterus to contract. So if you want to ripen the cervix, what you want, you need a prostaglandin at cervix. At the level of cervical region, you need prostaglandin. So how can you stimulate the cervical tissues to produce the prostaglandin? When there is an inflammation, when there is a stretching, when there is a necrosis, when there is a ischemia, when there is an inflammation, prostaglandin will produce. Do you understand? So that's why when a patient has infection, any kind of infection, especially UTI, Candida, whatever the infection, even the systemic infection, there will be a prostaglandin that will stimulate the labor, so patient will develop preterm labor. Right? So any condition which stimulates the prostaglandin, which can stimulate the labor. So these days, last 2 weeks in my ward, I'm getting so many patients with abdominal pain. Patients are getting pain. And so today when I'm doing the rounds, we had a chat with my MOs when I'm doing the rounds. So what is the reason for the prostaglandin, this admission due to pain? A lot of patients are admitting due to pain. So I suggest one reason. So that may be possible, right? Because nowadays it's quarantine, so you can't go out. So when the people are at home, husband is at home, what will happen? Sexual intercourse. Sexual intercourse itself can stimulate the labor, prostaglandin production and labor. So now they are doing the study. Can sexual intercourse induce the labor? So in Western world, they are advising you can have sexual intercourse after term. Frequent sexual intercourse might stimulate the spontaneous onset of labor. Do you understand? So maybe we don't know, right? So these are the pathophysiological explanation. So here they are asking method of cervical ripening Foley into the cervix. True or false? In the cervical canal, you are putting the Foley and you are inflating. When you are inflating a substance inside the cervical canal, it is stretching. When it is stretching, what will happen? It will stimulate the prostaglandin. So it can cause ripening. That's true. Prostaglandin F2 alpha. So you are inserting the prostaglandin from outside to ripen the cervix. True or false? False. Yes, of course, you can do prostaglandin insertion that will stimulate the labor, that will ripen the cervix, but this type of prostaglandin we are not using. There are 3 types of prostaglandin commonly we are practicing in obstetrics and gynecological practice. One is prostaglandin E1, second one is prostaglandin E2, third one is prostaglandin F2 alpha. Prostaglandin E1 is misoprostol, that is we are using for the miscarriage. So prostaglandin E2 is danoprostol, that is we are using for the induction of labor. That one we can use for the cervical ripening. And third one is prostaglandin F2 alpha, that is carboprest, that cause severe contraction. We don't use for the cervical ripening or uterine contraction. That will be used for the management of postpartum hemorrhage. Very good. We are using that prostaglandin F2 alpha for postpartum hemorrhage. Right? Okay, very good. I'm expecting my students to answer like this. Tuck, 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 tuck. So it should come. So your brain needs to think in this way. Quickly you have to think. And when you see the question, so if you want, you can ask your previous batch students. Most of the students, they got more than 60 marks in last time. So almost more than 90% of students got through from my classes. Even those students got more than 60 marks. Right? So I think in ERPM history, around 3 or 4 students only got through obs and gynae. Rest of the subjects, they fail. So usually it's happening in the other way around. They pass all the subject, then they fail obs and gynae. This time they pass only obs and gynae and fail rest of the subject. Right? It's because they understood the subject. So that's why they could pass the exam. So if you are, it's not a rocket science. Right? So passing the exam, it's not a rocket science. If you understand the subject, right, you can pass. That's it. Okay? Right. So prostaglandin F2 alpha, false. We are not using because that is for the PPH. Prostaglandin E2 vaginally. Yeah, that's true. Prostaglandin E2 is danoprost. I told you we can use for the induction. That's true. Artificial separation of membrane. What do you think? So if you do like this for some time, what will happen? If you do like this for some time, after certain minutes, you can see there will be redness and warmness. So if you kiss your girlfriend for a long time, then the lip will, what will happen? Inflamed, swell, red, isn't it? Because when you are manipulating something, that will stimulate the inflammation. Same thing, you are putting the finger inside and you are separating the membrane from the uterus. It will stimulate the inflammation and prostaglandin ripening. So that is one way of induction of labor. That's true. Oxytocin infusion. True or false? False, right? It's because oxytocin will cause the uterine contraction, will not cause ripening. Very good. It's false. So answer for question number 4. True, false, true, true, false. Right. Question number 5, twin pregnancy. So this is a very good question. So ARM. Yeah, ARM also will stimulate the uterine contraction. So ripening actually not the purpose of ARM, but of course it will stimulate the prostaglandin. ARM will stimulate the prostaglandin and it will cause cervical ripening as well. Right? Okay. Fine, no worries. So these free classes, I will edit the videos and I'll put it in my platform, so then you can access later also, right? No worries. Right. So twin pregnancy. Right. So what is twin pregnancy? So the twin pregnancy, this question is basically regarding the monochorionic, diamniotic, blah, blah thing. So to understand this one, you need to know three things. What are the three things? One, zygosity. Second, chorionicity. Third, amniosity. What do you understand by zygosity? Right. So the zygosity is, okay, normally what will happen? Yeah, let me to explain. So one ovum, one sperm fertilize to form a baby. This is a normal phenomenon in pregnancy. Okay, right. So in twin pregnancy, we can have two scenarios. One, two ovum, two separate sperm fertilized and form two babies. Here, everything is different. Two separate ovum, two separate sperm, two separate baby. So this is called dizygotic. There are two zygotes, dizygotic. So if it is a dizygotic, right, this baby will have own placenta and own amniotic sac. This baby will have different placenta and different amniotic sac. Do you understand? So in this pregnancy, both babies have two placenta. So we call it as dichorionic. Two amniotic sac, two bags, different bag. That is called diamniotic. So you need to know this always, these dizygotic twins. Always dizygotic twins will be having different placenta, different sac. Always will have dichorionic, diamniotic. Do you understand? This is the second scenario. One ovum, one sperm, fertilize, form a baby. Now, after forming this baby can divide into two babies. At the initial time, when there is a single cell or two cell, 4 cell, 8 cell, 16 cell, a small mass, that time, this one can divide into two babies. So here you can see one ovum, one sperm, monozygote. Monozygote. When monozygote divide, that will give rise to two babies. Do you understand? So monozygote divide into two babies. This is called monozygotic twin. So first of all, you need to understand dizygote and monozygote. Dizygote is two separate baby and two separate ovum, two separate sperm. Monozygote means one ovum, one sperm. But depend on the day of cleavage. Depend on the day of cleavage, the chorionicity and amniosity will vary. Because, right, when the baby is dividing, this will happen. Initially, very early, the first division part is placenta. The first part will dividing part is placenta. Second dividing part is amniotic sac. Finally, baby. This is how it's dividing. right? So finally, the baby. So here, right, if the cleavage occur between 0 to day 3, it means, I don't know your understanding, so please try to understand. Say, for example, today, ovum and sperm join and fertilize to form a single baby. So today is the day 0. Tomorrow will be day 1. Day after tomorrow, day 2. Next day will be day 3. So from today to coming 3 days, that is called the age is 0 to day 3. So within that 3 days, placenta need to be separate. If the baby divide, only placenta will separate. So if the baby divide within 0 to day 3, what will happen? Placenta also will be separate. So if the placenta separate, as we know, the first part is placental separation now. If the placenta separate, obviously rest of the things will be separate. So if the placenta separate, obviously the sac will be separated, baby will be separated. So baby is going to be dichorionic, diamniotic. Because everything will separate and different stuff, right? So dichorionic and diamniotic. If the separation occur from day 4 to day 8, if the separation occur day 4 to day 8, it means the placental separation only will occur in the early part now. If it is beyond 3rd day, placenta will not separate. Placenta will not separate. So there will be a one placenta. But sac can separate. So these two babies will get the blood supply from one placenta. So this is going to be a monochorionic diamniotic. Understood? Great. If the separation occur from 9 to 12 days, it means your amniotic sac also can't separate. So one placenta, one sac, two babies will get the blood supply from the one placenta. So how do you call this one? This is called monochorionic, monoamniotic. Okay. If the separation occur beyond 13 days, your baby also will not separate properly. So baby will be separate half. So one placenta, one sac, partially separated baby. How do you call this? This is called conjoined twin. Conjoined twin. Joint babies. So monozygotic twin can give rise to any kind of presentation. Dichorionic diamniotic, monochorionic diamniotic, monochorionic monoamniotic, or conjoined twin. So if you have this background knowledge, now you can do this question. Okay, right, we'll do the question. Monozygotic twins are always monochorionic, diamniotic, true or false? Monozygotic twin always monochorionic, diamniotic, true or false? It's false, I told you. Monozygotic depend on the day of cleavage, it can be anything. Dichorionic diamniotic, monochorionic diamniotic, monochorionic monoamniotic, conjoined twin. Anything can happen in monozygotic. So it's false. Dizygotic twins are dichorionic diamniotic. True or false? If it is dizygotic, always dichorionic diamniotic. True or false? Yeah, it's true. I told you. Right? Yeah, good. Dichorionic twin can be seen by ultrasound scan in 2nd trimester. That's true. From 11 to 13 weeks, you can identify chorionicity and amniocity. There are ways to measure the chorionicity and amniocity. I'm not going to explain because already I took a lot of time for this question. So we will do that one in a different question. So we can see the number of placenta. We can identify a few features like lambda sign or twin peak sign. Third one is intermembrane thickness, right? So we can assess the intermembrane thickness and find, right? So there are ways to assess the chorionicity and amniocity that can be done in second trimester. That's true. Incidence increased by ovulation induction. Twin pregnancy incidence increased by ovulation induction. True or false? Yeah, that's true, because when you induce the ovulation, so the ovum will produce more than one, which can cause multiple pregnancy. That's true. All monozygotic pregnancies are monochorionic. All monozygotic are monochorionic. False? True? It's false. If the cleavage before before day 3, it is dichorionic. So it's false. Now you all understand, I guess, right? So chorionicity and amniocity. If you don't understand, I'm really sorry. Causes for the heavy menstrual bleeding, right? What are the causes for the heavy menstrual bleeding? As we know, there is a FIGO classification for the heavy menstrual bleeding causes, right? So it could be a structural, it could be a functional, right? So very good, how to remember that is PALM coin, right? So PALM, 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 that is structural causes. COEIN, that is coin, is a functional. PALM, PAIN, right? PALM, PALM, that is structural causes. P for polyp, A for adenomyosis, L for leiomyoma or fibroid, M for malignancy, right? PALM, P for polyp, A for adenomyosis, L for leiomyoma or fibroid, M for malignancy and hyperplasia. Functional cause, COEIN, C for coagulopathy, some problem with the coagulation, O for ovulatory dysfunction, E for endometrial function problem, I for iatrogenic, N for not classified yet, right? Those are the causes for the heavy menstrual bleeding. Now they are asking causes for the heavy menstrual bleeding. Adenomyosis, true or false? Of course it's true, because it is a structural cause for the heavy menstrual bleeding. That's true. Endometriosis, yeah, endometriosis can cause heavy menstrual bleeding because endometriosis will increase the inflammation into the pelvis. So pelvic blood flow will increase. So ultimately it will cause heavy bleeding as well as severe pain. Dysmenorrhea and menorrhagia. These are the feature of heavy menstrual bleeding, also endometriosis. That's true. Retrograde uterus. Retrograde. Do you know what is retrograde? Retroverted uterus. Sometime it might be true, because retroverted uterus could be due to endometriosis or PID, which can cause heavy bleeding. But retrograde uterus, there is nothing called retrograde uterus. That is false, right? Asherman syndrome. True or false? What is Asherman syndrome? What is Asherman syndrome? Anyone? What is Asherman syndrome? Yeah, Asherman syndrome is fibrosis of the endometrial cavity, right? Or adhesions due to fibrous tissue formation. So when the endometrial cavity becomes fibrosis, what will happen? The endometrial tissue will reduce. When the endometrial tissue reduces, what will happen? Bleeding will be less. You can't have heavy bleeding. Maybe amenorrhea or oligomenorrhea, not the heavy bleeding. So Asherman syndrome, false. Pelvic tuberculosis. That's true, because pelvic tuberculosis is a pelvic infection. Infection can cause inflammation and increase blood flow to the pelvis. Yeah, it can cause. True. So answer for question number 6, true, false, true. Right. Next question. What are the causes for vulvovaginitis in a 10-year-old girl? So when you read the question, very careful, right? What are the causes for vulvovaginitis? It means vagina and vulval inflammation in 10-year-old girl. So when you do the question, so you can see in my paper, I mark that 10 year. Always when you do the question, so you can see I mark the 10 year. Why? Because when you read the question, you need to find the keyword. Here the keyword is 10-year-old girl. Because the courses will vary for a 10-year-old girl, 40-year-old girl, lady, and 80-year-old Archie. Do you understand? Right? So here the question is, what are the causes for vulvovaginitis in a 10-year-old girl? Vulval CA, true or false? It's false, because vulval CA is a common presentation of elderly. You can't have vulval CA at young age, especially at 10 years. So it is not possible at all. So vulval CA, it's false. Foreign body, that's true. 10-year-old girl can have foreign body, right? Maybe accidental foreign body, or maybe intentional foreign body, whatever. Foreign body can be inside the vagina. It can cause inflammation. Yeah, that's true. Sexual abuse. True, right? So 10-year-old lady, very young girl, somebody can abuse and it can cause infection and inflammation. Yeah, sexual abuse, yes, true. Vaginal septum. Vaginal septum, there could be a septum, but it won't cause vulvovaginitis. So if you have a transverse vaginal septum, what will happen? It will obstruct your genital pathway. When it is obstruct the genital pathway, what will happen? The blood will not, so the menstrual bleeding will not come out. So since the birth, her outflow is obstructed, so she can't have bleeding. So then she will present to you with primary amenorrhea, not the vulvovaginitis, right? She can't have menstrual bleeding because the path is blocked, right? So it's false. And cervical cancer, cervical CA, again it's false, because cervical CA, it is a disease of bit elderly, because as we know, the cervical cancer need long latent period. From the normal tissue to malignant tissue transformation need long latent period, from 10 years to 20 years. You need a long period to convert for the conversion of malignancy. So at 10 years having cervical CA is unlikely. Second thing, what is the commonest cause for the cervical CA? Very good. Human papillomavirus, right? Human papillomavirus. So HPV. So this papillomavirus, 99.7% is due to papillomavirus. So this HPV infection is a sexually transmitted disease. So at 10 years, inoculating HPV by sexual intercourse and becoming malignancy is unlikely. So it's false. So answer for question number 7, false. 2, true, false, false. Right. Question number 8, treatment of endometriosis. Okay. First of all, before you know the answer for this treatment, first you need to know what is endometriosis and what is the reason for the bleeding and pain. So what is the meaning of, or what is the definition of endometriosis? The endometriosis is presence of endometrial tissue and glands outside the endometrial cavity. So usually endometrium will present inside the endometrial cavity. Sometimes this endometrial tissue might present outside the endometrial cavity. Do you understand? It might present outside the endometrial cavity. So what is the problem? Okay, it can be in the outside. What is the problem? The problem is this endometrial tissue has ability to respond to the hormonal changes. Do you understand? So when there is ovulation, when there is a hormonal changes occur, right? When there is a hormonal changes occur, whether the endometrial tissue present inside the cavity or outside the cavity, that will respond to the hormonal changes, because during the follicular phase, estrogen level will go up in the bloodstream. Then again, what will happen? The progesterone will maintain the secretion. Then during the menstruation cycle, the progesterone and estrogen will come down, the endometrium will shed off and they will bleed. Do you understand? So even the endometrial tissue present outside the endometrial cavity, those endometrial tissue will expose to this estrogen and that endometrial tissue also will proliferate. That endometrial tissue also will proliferate and they start to secrete. And during the menstrual cycle, that endometrial tissue also will shed off and bleed. When the endometrial tissue which present inside the cavity, when it is shed off, it will come through the cervical opening as a menstrual bleeding. But when the endometrial tissue is outside the endometrial cavity, like in the peritoneum, or maybe in the bowel, maybe in the bladder, what will happen during the menstrual cycle? The endometrium will shed off. As we know, this menstrual cycle is inflammation. So prostaglandin will reduce, so will release, and it causes pain. So patient will have severe pain, painful menstruation. And there will be inflammation in the pelvis, in the bladder, in the rectum, in the lungs, in the brain. So inflammation will cause pain, dysuria, dysphagia, painful defecation. So pain. Second one, they will bleed with the urine. So cyclical hematuria, cyclical PR bleeding, cyclical hemoptysis. Do you understand? Fibrosis due to inflammation, narrowing of the tubes. Those are the problems. So if you want to treat the patient, what you want to do, one, you can treat them symptomatically. Like if the patient is having heavy bleeding, you just give some medication to reduce the bleeding like tranexamic acid. If the patient is having severe pain, you can reduce the pain because this is a pain due to prostaglandin. So if you stop the prostaglandin production, that will reduce the pain. So what is the medication will stop the prostaglandin production? NSAID. NSAID. So then you can give mefenamic acid. Any kind of NSAID will reduce the pain. So those are symptomatic management, like tranexamic acid and mefenamic acid. Or you can treat the disease. What is the disease? The endometrium is proliferate and shed off. So if you can stop the proliferation, if you can stop the shed off, then she won't develop any inflammation. She won't develop any pain. So you need to stop that particular mother mensurating. If she menstruates, there will be inflammation, there will be pain. So make that mother not to menstruate. How do you call that? Not menstruating. How do you call that? Amenorrhea. So you need to make that mother amenorrhea. So what is the easiest way to make her amenorrhea?
Pregnancy?
Yes, make her pregnant. That's it. Once she becomes pregnant for 10 months, she will not menstruate. So she won't develop pain. She won't develop inflammation. She won't develop heavy bleeding. Right? So you can make her pregnant. That is one way. Second one, you can make her pseudo-pregnancy or pseudo-menopause. So it's not pseudo-pregnancy, pseudo-menopause. You can make her pseudo-menopause. Right? Once she reach menopause, once she stop menstruation, no problem. So you can make her pseudo-menopause. How to do that? You can give GnRH. You can give hormonal suppression continuously. If you give interval between, then endometrium will shed off. But if you give continuous hormonal suppression, then the endometrium will not shed off. This is how we are managing. Now you can do the question. So treatment for the endometriosis, mefenamic acid, true or false? Yeah, true, because it will reduce the pain. Danazol, yeah, that's true, because danazol is androgen agonist that will stop the ovulation and it will make her amenorrheic. But only problem with the danazol. What is the problem with the danazol? What is the problem with the danazol? Yeah. So actually, it will cause androgenic, permanent androgenic side effect. Right? So then that lady will develop hair on the face, right? And voice change. Hello, don't actually because it. So then voice change. So it is permanent, irreversible. So that's why we are not giving this danazol as a first line treatment. But you can give. Right. So danazol true. COCP. Yeah, that's true. Because you are suppressing the endometrium with the hormone, but you have to give the COCP in a continuous manner, not the cyclical manner. If you give cyclical manner, she will menstruate. So you need to give continuous manner. GnRH analog?
True.
True. Clomiphene citrate. What is clomiphene citrate?
Ovulation induction.
Very good. It is an ovulation induction agent. So if you give the ovulation induction agent, what will happen? Ovulation will induce, estrogen will come, progesterone will come. Ultimately, what will happen? Your endometriosis will get worse. Isn't it? Good. Right. So answer for question number 8, true, 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 false. Right. Question number 9, diagnosis of a patient with polycystic ovarian syndrome. Right. So how do we diagnose the PCOS? There is a criteria called, what is the name of the criteria? Rotterdam criteria. Very good. Right. Rotterdam criteria we are using to diagnose the PCOS. So in Rotterdam criteria, we have 3 things. Out of these 3, if you have 2, you can diagnose. What are those 3 things? 1, menstrual irregularity, commonly amenorrhea or oligomenorrhea, right? Menstrual irregularity, that is the first criteria. Second one is, what is the second one? Clinical or biochemical features of hyperandrogenism. What are the clinical features? Hirsutism, acne, voice change. Those are clinical features of hyperandrogenism. Or biochemical. So you can do the biochemical feature. You can do the biochemical test, testosterone level. So testosterone level is higher. Biochemical feature. That is second. Third one, ultrasonic appearance of polycystic ovary. More than 12 follicles in the ovary, or the ovarian volume more than 10 milliliter. Ultrasonic appearance of the polycystic ovary. Out of these 3, if you have 2, you can diagnose polycystic ovarian syndrome. Right? But what will happen? Why these patients will develop androgenic side effect? Why these patients will develop hyperandrogenism? There are 2 reasons. One, the androgen production will increase. That is one. Second thing, when the patient develop insulin resistance from the ovary, androgen binding globulin protein, right? So this sex hormone binding globulin, because these hormones are protein bind hormones, right? So the free hormones have action. So majority of the hormones will bind to the protein. Those are inactive form. When it is released from the protein only, it will have action. So in PCOS ladies, because of the insulin resistance, this androgen binding protein production will reduce. When you have less number of androgen binding protein, right, what will happen? Here the androgen secretion is increasing, but protein level reducing. So then what will happen? The free androgen in the blood will increase. So when you have free androgen, that will have androgen side effect. That's why for PCOS ladies, we are giving OCP. When you give OCP, OCP has estrogen. Estrogen will stimulate the protein synthesis. So when the protein synthesis is stimulated, androgen binding globulin will increase. Sex hormone binding globulin will increase. So then androgenic side effect will come down. Do you understand? But this androgen binding globulin or sex hormone binding globulin level will not be included in the diagnostic criteria, but sex hormone binding protein level will be reducing in PCOS. So the question is, diagnosis of patient with polycystic ovarian syndrome, increase serum sex hormone binding globulin. Obviously, it's false, right? Obviously, it's false, right? Obviously, it's false. But this sex hormone binding globulin, we are not taking into the diagnosis as well. Diagnostic criteria, it's not. Yeah, it's false. Hirsutism, will it be taken into the diagnostic criteria? Yeah, that's true. Obesity actually a feature, but obesity, it's not the diagnostic criteria. Okay. So hirsutism, true. Increase androgen. Androgen concentration increase. Hyperandrogenism is a criteria, true. Dysmenorrhea. Actually, PCOS does not have painful menstruation. It's false, right? Obesity. Obesity, yeah, of course, they will obese. 70% of the PCOS ladies are obese. 30% of PCOS ladies are lean body. right? 70 to 80 obese. But obesity will not be included into the criteria. Okay, so answer for question number 9, false. 2, true, false, false. Right. Question number 10. Woman with postmenopausal bleeding. Right. So if a patient presented with postmenopausal bleeding, what do you understand by postmenopausal bleeding? Bleeding through the vagina after the menopause. Usually after the menopause, you don't get bleeding. If somebody presented with bleeding through the vagina after the menopause, we need to intervene. We need to assess. Because what are the causes for the postmenopausal bleeding? What is the commonest cause for the postmenopausal bleeding? Very good. 60% is due to atrophic vaginitis, 30% is due to polyp, 10% is due to endometrial CA. Commonest cause due to atrophy, second commonest cause is polyp, third one is endometrial CA. Other causes are cervical CA, infection, trauma. Those are the causes for postmenopausal bleeding. So, as the endometrial CA and cervical CA, one of the cause, whenever patient presented to you with postmenopausal bleeding, this is mandatory to assess the endometrium and cervical status. Never ever you can't reassure the patient and send. If the patient presented with postmenopausal bleeding, just put the speculum and see whether cervix is healthy. Is there any features of cervical cancer? Just check her pap smear status and do the transvaginal scan to assess the endometrial thickness and regularity. If the endometrial thickness is more than 5 millimeter, you have to suspect the malignant risk is a bit high. You need to take the piece of tissue biopsy to confirm the malignancy. This is how we are assessing the patient with postmenopausal bleeding. So when a woman presenting or coming with postmenopausal bleeding, you need to take the Cone biopsy. No, we are not taking the Cone biopsy for all patients with postmenopausal. Just put the speculum and see whether the cervix is healthy. If the cervix is unhealthy, if you are thinking whether it's malignant, then we are not taking the Cone biopsy. We take the punch biopsy. So Cone biopsy is false. Endometrial thickness by transvaginal ultrasound scan. Yeah, of course. You need to assess the endometrial thickness by a transvaginal scan. That's true. Estrogen MRI scan. Actually, MRI scan is not the first line treatment. If you confirm the malignancy, to assess the spread of the malignancy and stage the malignancy, you can do MRI. Otherwise, you don't need to do the MRI. So that's false. Estrogen for 3 weeks. What do you think? Will you give estrogen for the postmenopausal lady? Of course. One of the treatment for the postmenopausal bleeding is estrogen, because as we know, what is the commonest cause for the postmenopausal bleeding? What is the commonest cause? Atrophic vaginitis. So if the vagina got atrophy, what is your treatment? Give estrogen, because estrogen is the one bring down the blood to the pelvis. So you can give local estrogen. But before you give the estrogen, you need to exclude the malignancy, because if it is a malignancy, if you give estrogen, your malignancy will get worse. Always you have to exclude the malignancy. Once you exclude the malignancy, only you can give estrogen. So estrogen for 3 weeks. When patient coming with postmenopausal bleeding, estrogen for 3 weeks, no. We are not giving as a first line. First, you exclude everything, then you can think about the estrogen, right? So total abdominal hysterectomy, we may have to do if it is a malignancy. If the patient presented with postmenopausal bleeding for the atrophic vaginitis, are you going to do the TH? No, we are not. If it is a polyp, are you going to do the TH? No, do the polypectomy. No, it's false. So total abdominal hysterectomy, false. So answer for question number 10, false, true, false, false, false. Right. We'll move to SBA. Question number 1. A pregnant woman had a cord prolapse while doing ARM. What is the first step of management? It is a straightforward question, nothing to explain, right? So here, when the cord comes below the presenting part, called cord prolapse, when the cord comes out, there are 2 problems. So you need to understand the principle. When the cord comes out, there will be 2 problems. What are those 2 problems? One, when the cord is exposed to outside. When the cord is exposed to outside. What is the body temperature? It's 37. What is the environmental temperature? It's 30. So it is hypothermic. So when the cord is exposed to hypothermic environment, okay, when the cord is exposed to hypothermic environment, because of the hypothermia, the cord will get spasm. Cord spasm. So cord spasm will cause cut down of the blood flow to the baby, then baby will develop hypoxia and baby might die. So you need to keep this cord in the body temperature. So then what we are doing, we are just putting the cord into the vaginal canal and pack the vagina with warm saline soap. Go swap. That is the first step. Never ever push the cord into the uterus, because if you push the cord into the uterus, you might damage the cord, you might compress the cord. So you just put it into the vagina and take her to the theater and cut the mother and take the baby out. Second thing, when the cord is coming below the fetal head or presenting part, that presenting part might compress the cord. So then what you want to do, you want to push the presenting part up. How to push the presenting part up? There are ways. One, you can fill the bladder. When the bladder is filled, then it will push the presenting part. Second, you can keep the baby in a kneel chest position. So when you keep the kneel chest position, the chest is lower, knee is upper. So because of the gravity, presenting part will come down, the compression will reduce. Third one, you can manually displace the uterus, presenting part, and you can take her to the theater. So these are the way we are doing to displace the presenting part towards the up. So manual elevation, bladder filling, knee chest position, right? So here they are asking, if women develop cord prolapse, what is the first step of management? First step of management, put the cord into the vagina. That is the first part. Then only you have to push the presenting part. So put the cord back into the vagina. Right? Use ventouse. Ventouse means vacuum. So you can't use the vacuum, right? Because when you can use the vacuum, when there is a fully dilatation. Otherwise, you can't, right? Fill the bladder. Of course, we will fill the bladder after putting the cord into the vagina. So in single best answer, you need to. So there might be 2-3 correct answer. You have to find the most suitable answer. Put the head down. Yeah. If you put the mother's head down, lower part up, then because of the gravity, the presenting part will come down, right? And put the patient on left lateral. No, left lateral, it's not going to work anyhow, right? So answer is A. Question number 2. Most appropriate phrase to describe the progression of the first stage of labor till 4 centimeters. Actually, you don't need to worry. So the students, once we have discussed the mixed paper earlier. So usually I do the exam series like your exam, 6 papers we will discuss again once the exam date announced. So until we start the exam series, we will do this free paper session. Okay. So then you all can continue to study, right? So most appropriate phrase to describe the progression of first stage of labor till 4 centimeters. Okay. What are the way to assess the progression of labor? How do you assess the progression of labor? There are 2 ways. One, if the labor is progressing, cervix will dilate. Earlier it's closed, now is 1 centimeter, 2 centimeter, 3 centimeter, 4 centimeter, 5 centimeter, 6, 7, 8, 9, 10. 10 is the fully dilatation stage. So one way of assessment is cervical dilatation. Second one, when the labor is progressing, the baby will come down, descent of the baby. Baby will come down, descent of the baby. Right. So how to assess whether the baby is coming down or not? There are 2 ways. One, you can do the abdominal examination and see whether the baby is coming down. Or you can do the vaginal examination and you can assess the descent by station. Earlier it was station -3, now station -2, now station 0, now station +1, +2, +3, which means baby is coming down. So the descent and dilatation will be the way of assessment. right? So the fetal descent will occur usually in the later part of the labor, right? So especially in the early part of labor, cervical dilatation will be the best way to assess the progression. So anyhow, there are two ways to assess the labor progression. One is dilatation, another one is station. But in early stage, the dilatation will be the best way. So answer for question number 2 is A. Question number 3. A pregnant woman in the second stage of labor for 2 hours. A pregnant woman in second stage of labor for 2 hours. Uterine contraction, will it come to assess the progression? No. Uterine contraction, it is not assessing the progression of labor, okay? Because uterus might contract. It is not saying the labor is progressing or not. So that's why I'm telling. So whether you are studying, how many hours you are studying, no, it will not reflect your pass rate. Your successfulness is mainly determined by your reproducibility, right? So there are two ways only we can assess. One is the dilatation, second one is descent. Effacement also will not say whether the labor is progressing or not. You can say whether labor is started or not. You can assess the feasibility of the labor. You can assess the suitability of the labor with the effacement. But progression will be assessed by the dilatation and descent. Right. Question number 3. A pregnant woman in second stage of labor for 2 hours. On vaginal examination, baby was in phase presentation where the mouth, eye could be felt. Mentum is at 9 o'clock position. Cervix is fully dilated. What is the most appropriate management? What is the most appropriate management? Okay. Now, baby is in a phase presentation. So, in phase presentation, depend on the denominator. What is denominator? Do you all know what is denominator? Denominator is bony prominence of the presenting part, isn't it? Bony prominence of the presenting part. So if it is a face presentation, when the baby is in a face presentation, what is the bony prominence? Is chin, mentum. So depend on the mentum, we can assess the position of the baby. We can assess the position of the baby. If the mentum is related to the maternal pubic symphysis, that is called mento-anterior. If the mentum is related to the maternal sacrum, that is called mento-posterior. If the mentum is related to the maternal side wall, that is called mento-transverse. Right? So among these positions, whether it could be a mento-anterior, mento-posterior, or mento-transverse, among these positions, only mento-anterior can deliver vaginally. Mento-posterior, mento-transverse, it's not possible to deliver vaginally. You can't deliver. Why you can't deliver? I will explain in the labor mechanism, not now, because it's take 15 minutes to explain, right? But you need to know that mento-anterior only you can deliver vaginally. Mento-posterior and mento-transverse, you can't deliver vaginally. So if it is a mento-posterior and mento-transverse, it is an absolute indication for cesarean section. It is an absolute indication because it is not possible to go for a vaginal delivery. Cut the mother and take the baby out. But say, for example, if it is a mento-transverse in 5 centimeter, will you do the cesarean section now? No, we don't do, because we have time. When the labor progress, this baby can turn into mento-anterior position. So you can wait for some time. If it is a mento-transverse or mento-posterior, you can wait for some time and see whether it's turning or not. If not turning, then you can go for a cesarean section. But here, this patient is in second stage of labor for 2 hours. It means already fully dilated and 2 hours gone. So are you going to wait further? No. because you have reached the maximum time limit. There is no place for the waiting further. So if it is a menotransverse in second stage of labor, already 2 hours gone. So then immediate cesarean section will be the answer. So answer is C. Question number 4. A primary gravid in twin pregnancy after first baby found to have second baby in transverse lie with shoulder presentation. What is the management? What is the management? What is the management? LSCS. Right. So in question number 1, I told you, we are doing the section only for the leading twin. If the leading twin is in non-cephalic presentation, do section. There is no question. But if the leading twin is cephalic presentation, we are not worrying about the second twin. Just forget about the second twin, deliver the first twin. Once you deliver the first twin, then assess the second twin. If the second twin also in cephalic presentation, do ARM and take the baby out. If the second twin is in non-cephalic presentation, like transverse lie, oblique lie, or breech presentation, then what you can do, you can turn the baby to cephalic presentation from the outside. How do you call that? That is called external cephalic version, ECV. You can turn the baby to cephalic presentation, do ECV, turn the babies to cephalic presentation and take the baby out. Or if you are doing the ECV, it takes time. You turn the baby to cephalic presentation, then do ARM and let the baby to come out. So it takes time. But when the baby is in a transverse lie, fetal distress, you need to deliver the baby very fast. So then you can't turn the baby and wait for another half an hour. So in that case, you need to take the baby immediately. So then what is the easiest way? You just put the hand inside the uterus, hold the baby's leg and pull the baby's leg towards vagina. So what you are doing, you are turning the baby to breech presentation. So internal podalic version. You are turning the baby to breech presentation. Podalic means leg. You are putting the hand inside the uterus, internal version turning. So you are turning the baby set by inside. So internal podalic version. Once you turn to internal podalic version, you can't let the baby to deliver spontaneously. You need to pull the baby out. That is called breech extraction. So in case of emergency, what we do internal podalic version and breech extraction. So internal podalic version always need breech extraction. So this internal podalic version and breech extraction can be done only for the twin pregnancy second baby, not for the twin pregnancy first baby or singleton pregnancy. Keep it in your mind. Only for the twin pregnancy second baby. That is second option. Third option, you can do cesarean section. Right? So here they are asking the first baby found to have first baby delivery, second baby found to have transverse lie. What is the management? ECV. We are not putting the hand inside the uterus first. In case of emergency only we do. Otherwise, ECV. So answer A. Question number 5. A 30-year-old primary comes with exertional dyspnea at 36 weeks of POA. Hemoglobin is 8.5. What is the most appropriate treatment? What is the answer? Okay. Keep it in your mind. Yeah. How we are deciding the management for the anemia is there are 2 factors. Okay? No, not 2, 3 factors. 1, period of gestation. Second, severity of the anemia. Third one, symptomatic status. Right? Okay, I'll come to that question. Right? So these are the 3 things: period of gestation, severity of the anemia, and symptomatic status. Right? So if the patient is in severe anemia, hemoglobin less than 7, has high risk to develop heart failure. So irrespective of POA, irrespective of symptomatic status, if the hemoglobin is less than 7, we need to give blood to prevent the heart failure. Do you understand? Second one, your period of gastration. If the patient is early POA, you have time to recover your hemoglobin, because your aim is maintain the hemoglobin at 10 during the delivery. The target hemoglobin during the labor should be 10. So if it is early POA, obviously you have enough time. So you can give oral iron or IV iron, whatever, you can recover the hemoglobin. But if the patient at 38 weeks, 39 weeks, she's going to deliver, you don't have time for the recovery, give blood. If it is 36 weeks, of course, you have time, another 2 weeks. So you can give IV iron and you can recover the hemoglobin. So this is how we are deciding. And third one, symptomatic status. Irrespective of period of gastration, irrespective of severity, if the patient is symptomatic anemia, give blood. That's it. If the patient is symptomatic, give blood. That is the treatment. You can give the blood, then only you have to correct the iron. So here, a 30-year-old primate with exertional dyspnea, it means symptomatic anemia. Right? Hemoglobin is 8.5, 36 week. Of course, 8.5, 36 week, you can give IV iron, you can recover. But only problem, you don't have time. Sorry, patient is having symptoms. So then, as the patient is symptomatic, you need to give blood. The answer is blood transfusion. Okay, somebody asked, if it is a shoulder presentation, it is not an emergency. No, because why it is a shoulder presentation? Because the baby is in a transverse line. Turn the baby to oblique longitudinal line to the cephalic presentation. It's not an emergency. It's false. Right. Okay. Question number 6. A 35-week pregnant mother presented with headache. On examination, her blood pressure is 165/120. What is the most appropriate management? What is the most appropriate management? Okay, what is this condition? Severe preeclampsia. Agree. Right, so it's an impending severe preeclampsia, right? Because her blood pressure is very high. She's having headache, means already the fluid has been leaked into the brain. So as her brain has edema, what she will develop fits. How do you call that? How do you call that fits? That is called eclampsia. So she will develop eclampsia. She's not having eclampsia yet. She will develop eclampsia. That's why we say it is a pre-eclampsia, not an eclampsia. It is a pre-eclampsia. Do you understand? This is a pre-eclampsia, right? And second thing, as her blood pressure is very high, her mean arterial pressure more than 125. When the mean arterial pressure is more than 125, the risk of intracranial hemorrhage is very high. Here, her systolic blood pressure is 165, diastolic is 120. So her mean arterial pressure is more than 125. So she has high risk to develop intracranial hemorrhage. So if you want to sort out all these problems permanently, what is the treatment? Deliver the baby, because of the placenta only she develop all kind of complications. So the definitive management for this condition is delivery. But even if you deliver the baby, you take time for the cesarean section. So during that time, she will develop ischemic intracranial hemorrhage. She will develop fits, so which can kill the patient. So what you want to do, you want to do some treatment, or you want to give some treatment to prevent the intracranial hemorrhage, prevent the fits. At the same time, you need to do the definitive management, that is delivery. So here, obviously, if they ask what is the definitive management, is cesarean section. But what is the appropriate management means until you do the cesarean section, you need to prevent the intracranial hemorrhage and fits. Here, her mean arterial pressure is high. So she has risk for the ICH as well as fits. So which one is more dangerous and which one is high risk here? ICH or fits? Which one is more dangerous? ICH. So when they are asking in SBA, so in clinical practice, what we do to prevent the fits, we give max sulfate. To prevent the ICH, we give hydralazine to bring down the blood pressure. Agree? So in clinical practice, what we do, we give both parallelly. In one hand, we give max sulfate, one hand we give hydralazine. But when it is coming to SBA, you have to select one best answer. So what are you going to select? Hydralazine, max sulfate, or cesarean section? Which one is the most appropriate for this patient? Obviously, the most dangerous one. What is the most dangerous one can occur next? Which one you need to stop first? ICH. So hydralazine will be the answer. So max sulfate also correct, but the best answer, right? Best answer is hydralazine. So hydralazine can cause dramatic drop of blood pressure, can cause fetal death. Yeah, but hydralazine can cause blood pressure drop, but here you have to think about the mother, right? So always we have to think about the mother. So here the answer is A. If they ask what is the definitive management, what is the answer? C. You have to do cesarean section. That is a definitive answer. What is the next step of management? Hydralazine. When can nifedipine be given? Actually, the nifedipine is an oral drug. So it takes some time. So here the blood pressure is severe hypertension. So in severe hypertension, you need to give the IV antihypertensive, not the oral one. But if you don't have IV antihypertensive drugs, if you are working in a peripheral hospital as a MO, then you can give nifedipine sublingual. Why don't we give the nifedipine sublingual? Nowadays we don't give because that will dramatically reduce the blood pressure than the hydralazine. So it can cause fetal death. That's why we give IV hydralazine or IV labetalol. Nifedipine will be reserved for only when there is no IV drugs, right? Why hydralazine superior than max sulfate? Oh my God. That's why I'm telling you. Because max sulfate we are giving for prevention of fits. Hydralazine we are giving for the prevention of ICH. Which one is you need to give first for this patient? Is hydralazine. So answer is A. Question number 7. A 35-year-old primee presented with reduced fetal movement at period of 39 weeks. What is the first step of management? Induced with prostaglandin. CTG. Okay. Now, mother is presenting with reduced fetal movement. What could be the reason? Baby might be sleeping. Or baby might have hypoxia. Or baby might die. IUD, intrauterine death, we don't know. So, if a patient presented with reduced fetal movement, what is the first step? You need to check the fetal heart rate, whether baby is alive or not. How do you check the fetal heart rate? Either you can use the Pinart or you can use the handheld Doppler to check whether baby's heartbeat is there or not. Okay, baby's heartbeat is there. So it means if the baby's heartbeat is there when you check the Doppler, but baby is not moving. So what could be the reason? So baby is not died. So baby might be sleeping or baby might have hypoxia. Because when you are hypoxic, when you are hungry, you will not move, right? So you are not writing. You are just be in a dormant stage like this. So baby also same. When the baby is hypoxic, baby is not moving. So how do you identify whether baby is hypoxic or not? You can put the CTG. Then CTG will say whether the heart rate changes are there, whether baby is having hypoxia. If CTG is okay, then what you can check, you can do the scan, whether the fetal Doppler is normal. But as it is 39 weeks, if the patient has one episode, if CTG is normal, you can discharge. But if the patient is having second episode or more, recurrent reduced fetal movement, now it's 39, already baby matured, just induce and deliver. The first episode, you don't need to induce early, but if it is a second episode, you can induce. So here they ask 35 years, try me, reduce fetal movement at 39 weeks. What is the first step of management? First step, check the fetal heart rate with the handheld Doppler. If handheld Doppler is saying baby is alive, then just do CTG, then just do scan. So the answer is C. Question number 8. A woman presented with oligomenorrhea. What is the investigation finding for diagnosis? A woman presented with oligomenorrhea. What is the investigation finding for diagnosis? So patient is having oligomenorrhea. So you need to diagnose few conditions. So some conditions. So what is the test you will do to diagnose? So if it is an oligomenorrhea, what you are suspecting? What could be this one? PCOS. So if you want to diagnose the PCOS, as we discussed in MCQ, we need to conform by the Rotterdam criteria. So oligomenorrhea means one criteria is there. What is that? That is menstrual irregularity. What is the second one? Increase androgen. So you need to check the androgen level. Third one, you need to do the scan. So if you want to diagnose the PCOS, you need to check the androgen level. So here, increase androgen, increase estrogen, increase progesterone, normal FSH-LH, decrease LH. So here you need androgen level increase. So answer for question number 8, A. So question number 7, C. Question number 8, A. Question number 9, treatment of 1B cervical carcinoma in patient with no comorbidities. This is very straightforward question. Yeah. What is the answer for question number 9?
Radiotherapy and chemotherapy.
Radiotherapy. Why not decrease LH level for question 8? Actually, for in PCOS, LH level will be increased, not decrease. FSH level will come down, LH level will increase. Right, okay. So here, the cervical cancer treatment, okay, cervical cancer treatment, it's depend on the stage of the cancer, right? So cervical cancer can be staged by stage 1, stage 2, stage 3, stage 4. Stage 1 is confined to the cervix. Stage 2 spread to the vagina and parametrium. Stage 3 lateral pelvic wall extension, right? So in cervical CA, early stage of cancers can be managed by surgery. Late stage of malignancies will be managed with radiotherapy. Distant metastasis will be managed with radiotherapy and chemotherapy, right? So you have to give the chemotherapy and radiotherapy for stage 4, stage 3C, like that. So early stage will be managed with surgery, right? So the stage 1 further classified into 1A and 1B. What do you understand by 1A? 1A is micrometastasis. All kind of information is available in my book. So if you buy the book, you can see those things, right? So 1A is micrometastasis. 1B means macrometastasis, right? So 1A means it's less than 5 into 7 millimeter lesion. So very minimum, 5 into 7 millimeter. So what you can do, you can remove the particular part only, or you can remove only the cervix only. So you can do the cone biopsy, or you can take the cervix only. So that is called tachylectomy. So for 1A, we are not even you don't need to take the uterus. You can take the cervix or part of cervix. That's enough. But if it is 1B, means macrometastasis, macro lesion, means more than 7 millimeter. So if it is a large lesion, right, when you see there is a lesion in the cervix, so you can see the cervix, but along with the cervix, there could be some micrometastasis into the uterus, into the vagina. That one you can't see with your naked eye. So that's why if it is 1B lesion, just removing the malignancy, that part only, it's not enough, because there could be a small metastasis into the adjacent vagina as well as uterus. So what you have to do for the 1B, you have to take the uterus, but you don't need to take the ovary, because ovary does not have any problem. So you just keep the ovary, only take the uterus. But taking uterus alone, it's not enough. You have to take part of vagina as well, because there could be a micrometastasis. So you need to take part of vagina. So how do you call that? That is called radical hysterectomy. If it is 2A, 2A means the malignancy involved with the upper part of the vagina. Obviously, vagina involved, you could see. So then for that too also you can do radical hysterectomy. Take that vagina and parametrium, part of parametrium and uterus, radical hysterectomy. But if it is 2B, it means parametrium also obviously involved. In that case, you can't remove entire parametrium, because if you remove the entire parametrium, then morbidity will be high. Then patient will develop more complication. So rather than going for a surgery, you can go for a radiotherapy. So up to 2A, you can go for a surgery. Beyond 2A, you have to go for a radiotherapy. So here they ask, what is the management for 1B? So what is the management for 1B? Radical hysterectomy. So answer D. Radical hysterectomy, if the family is completed or have mum fertility vision, it is like that. So if a mother not completed the family, but 1B lesion more than 4 centimeter, in that case, you can't do tachylectomy, because already the lesion is larger. In that case, if you preserve the uterus or vagina, which can cause recurrence. So she's not suitable candidate for the fertility. So then you have to think about the mother and do the radical hysterectomy. If it is less than 4 centimeter lesion, then you can think about the radical tachylectomy. Only cervix along with the vagina, right? So that is possible. So here they ask about the 1B. So radical hysterectomy, answer D. Question number 10. A 17-year-old female presented with heavy menstrual bleeding. So if somebody, now I'm doing the restreaming of the previous mixed paper discussion. So only one class finished. That will be 12 classes, 2 hours class. So you all can join if somebody missed the class. So next class will be on Monday. Right. A 17-year-old female presented with heavy menstrual bleeding with regular cycle. What is the drug of choice? Now, this patient is 17 years, regular cycle, right? Presented with menstrual bleeding with regular cycle. She's having regular cycle. What is the drug of choice? OCP? Yeah, we can give OCP. Danazol, it's not an option because that will have a lot of side effect. Mefenamic acid, actually mefenamic acid will reduce the bleeding by 25%, but mainly we will use for that pain reduction. So what they are telling is, if you give the mefenamic acid, of course it will reduce the bleeding, but the side effect is more. For the bleeding reduction purpose, using the mefenamic acid is not recommended. So if the patient is having heavy bleeding, especially a regular heavy bleeding, what is the best thing is tranexamic acid, not the mefenamic acid. Okay. So mefenamic acid won't be an option. Aspirin we don't give to reduce the bleeding or pain. And dimethoxyprogestin, so DMPA we don't use for the heavy menstrual bleeding, because if you give the DMPA, that will cause a irregular period. So among this answer for this lady, the best answer is OCP. But if they mention tranexamic acid and OCP, what will be the best answer? Tranexamic acid. Because OCP will have two functions. One, OCP will reduce the bleeding and regularize the period. Tranexamic acid will reduce the bleeding, will not regularize the period. So the bleeding reduction by the OCP will be 50%, right? Bleeding reduction by the tranexamic acid will be like around 60%. So the tranexamic acid is more effective. Right? And whenever you treat, better to treat without hormonal treatment. Right? Whenever you treat, better to treat hormonal treatment. not non-hormonal treatments. Here they didn't mention tranexamic acid. That's why the OCP will be, even though it's a regular cycle, OCP will be the answer. Sir, why not mefenamic acid? Come on, good morning. I have told the reason why not mefenamic acid. Because mefenamic acid bleeding reduction is 25% and side effect is more. The mefenamic acid can be used for the pain reduction. For the bleeding reduction itself, we don't use mefenamic acid. So here the regular cycle. So do we need OCP? Yeah, the regular cycle or irregular cycle, OCP will have reduction of bleeding. But if it is a irregular cycle, OCP will be the best option. If it is a regular cycle, tranexamic acid will be the best option. But here tranexamic acid is not there. That's why we are selecting the OCP. So in this lady, regular cycle, so can't we use mefenamic acid because it's reduced the pain? But they didn't mention anything about the pain. Then why you are giving the mefenamic acid? Because I told you mefenamic acid has only 25% bleeding reduction and a lot of side effect, gastrointestinal side effect. So mefenamic acid we are not using for the purpose of bleeding reduction alone. If the patient is having pain, only we use mefenamic acid, right? So if without pain, only bleeding reduction, we don't use mefenamic acid. OCP has 50% reduction. Mefenamic has 25% reduction. OCP has less side effect. Mefenamic acid has more side effect. So then what will be the best answer? OCP or mefenamic acid? Can we use OCP in a 17-year-old girl? Yeah, of course. What is the problem? Why can't we use? You have to. You can. It's not a problem. Until the mother or her boyfriend think bad, why are you taking contraceptive drugs at 17 years? No, otherwise you can use. Okay. So answer is OCP. Okay. Thanks a lot. I think you have class. So, sir, if can please let you know in the WhatsApp group when the app is. Oh yeah, of course I will explain. So we will have a class through the app. Okay. So I will inform you the next free class. Okay. Okay. Thanks a lot. So if we consider the age only, does the DMPA is a good option? No, DMPA it's not a good option because, okay, I'll explain why it is, because she's 17 years, right? If you give the DMPA has only progesterone, right? At 17 years, she needs estrogen for her breast development and secondary sexual development. So if you give the progesterone alone, what will happen? It will affect the secondary sexual characteristics. So breast might get atrophied without estrogen. Because when you are giving the progesterone will suppress the follicular development. So the natural estrogen also will be less. So then her secondary sexual characteristic, breast development will affect. So especially for young women, if you want to give the hormonal treatment rather than progesterone, better to give the estrogen and progesterone. So you need estrogen for their secondary sexual characteristic development. Okay. Yes. Hello, Ashika. After a long time. Yeah, of course. We will do more live classes. Okay. So then we'll see maybe next week with another free paper. Okay. Bye.
Excuse me, sir.
Yes, Lagiro. Yes.
So, in question number 6, the pregnant lady is 35 weeks. So the blood pressure is 165 to 120.
Okay.
So can we do the reduce in hospitalizations if we reduce the blood pressure to normal level? Can she continue another 3 weeks or 4 weeks to the normal level?
No. The reason is you can't do that because already she developed headache, means she developed cerebral edema. So once the patient develops cerebral edema, it is dangerous to the patient. So you can't continue the pregnancy. If you continue the pregnancy, she will develop fits and she will die. So always you have to give the priority to the mother. So once the patient develops impending preeclampsia or eclampsia, irrespective of POA, you have to give the priority to the mother and deliver the baby immediately. Do you understand? We are not giving the
Yes.
priority to the baby. So if the patient develop impending preeclampsia or eclampsia, we do delivery.
Okay, sir. Thank you very much.
Yeah, no problem. So if it is mild preeclampsia, yeah, of course, we can continue the pregnancy until term. It's not a problem. We can hospitalize and monitor, and we can continue the pregnancy. Okay, great. So we'll meet next week. Bye.